This part of the lecture is going to follow pretty much the same track as the hematology lecture, in that I'm really going to talk about tips of creating good cytologies and what we recommend with cytology. And again, we've got some really great information on our website in the Animal Health Diagnostic Center. And we're going to be expanding over the next 20 years or so our teaching website, which I've given you the URL for, current URL as well as the one that's going to be launching in 2004 in August. So someone came up to me after the lecture and reminded me of two things that I should have said about hematology slides. Remember, everything is a snapshot in time, and hematology changes pretty darn quick. So honestly, if you've got a critical patient and you're monitoring them, I would recommend at minimum 24-hour, because we've seen hemograms change pretty much like that, particularly with leukocytes and platelets. Obviously, red cell's going to take a lot longer, but you can see immediate changes in those with resolving inflammation, worsening inflammation. The other thing and the other caveat is you don't treat the lab data, you treat the patient, okay? And that's always first and foremost. I say that to students, I say that to anyone who calls asking me about results. The first thing I'm going to ask is, tell me more about the case, so that I can put the data in context with the case, because everything is context dependent and everything is case dependent. And what we do as clinical pathologists is you really try and make a story out of what we're seeing that we can help you. And that story means that we're kind of making things fit into a picture, and we're using our best judgment to do that. And that's what we do as veterinarians all the time, is we try and let the animal tell us the story, and then we treat what we think is going on. Okay, so again, the outline is smear preparation and basic cytology principles. Again, I'm not here to teach you how to tell a round cell tumor from an epithelial tumor. I have given you in the notes some guidelines on the things that we look for. And I can also show you pictures of ones that we sit there and we take half an hour looking at the smear, because they're challenging cases. And with Cornell now being really a tertiary referral institution, we see some pretty challenging cases. And even the ones, because we read outside cytologies now, we get some cases that we scratch our heads about, and they're always interesting and frustrating, particularly if we don't get follow-up, because we want to learn from them so that we can do better next time. So, but essentially, our interpretation can only be as good as what we're looking at. So if the slide is a poor quality slide, we really struggle with those. So what I'm going to work through now is just how to make a good slide and the things that we've learned about making good smears. And again, I'm also going to talk quickly about the processes that we identify. And for the students that we teach, they always struggle with what do we mean by disease process? Because ClinPath is all about pattern recognition and disease processes. So if you've got high urea and creatinine, and we're after azotemia, and then we've got 3 types. And so for me, azotemia is a disease process that tells us that either there's dehydration or something going on in the urinary system. And so like inflammation is a disease process. And certainly what we look for is hemorrhage, inflammation, and cancer, and then we get fixated on these small little necrosis and all these other cool things. And again, you know, in cytology, even more than hematology, we have to tell fact from fiction, and there are things that mimic infectious agents all the time. There's things in urines that mimic infectious agents that we're like, oh my God, what are you? And a lot of it is match the picture, or, you know, what do I recall having seen a case 10 years ago? And what did I do with it at that time? Okay, so with cytology, what you want to do is make the most appropriate smear for the sample that you have. And really, this is dictated by what you have. And if it's a fluid sample, there's different things that we do. If it's a solid tissue aspirate, or you take a chunk of tissue that you make impression smears, it changes what you do. And if you're sending slides into a lab, they're going to want everything. Yes, we know you're going to keep a slide, and I encourage you guys to look at your own cytologies. But there's nothing that we hate more than Diff-quik. I hate to say that. But Diff-quik is really challenging. So send us everything you have, because you may think you've sent us the best slides, but you actually may have the only diagnostic slide in your hand. And then you've wasted, for us, maybe $40. sending a slide in there, we say, I'm sorry, it's non-diagnostic, and then you call us up and say, but we saw cells, and then we're like, well, send that slide in, and then there's a week delay. So send us what you have, and if you want it back, just let us know, and if we can, we'll give it back to you, but obviously we have to keep it for legal reasons. Give us a history, because if not, we'll definitely make up a really big story, or we'll make 2 and 2 equals 10. And keep out of contact with formalin, so if you're taking a surgical biopsy, because this is what happens when you try and stain it, is this is actually a lymphoma, but I wouldn't have any clue what this cell is. I can tell it's a neutrophil, but formalin gives this blue background, and it prevents the cells from being stained. So make your lives easier and keep it out of formalin. So if you're collecting, and for a lot of you in shelter medicine or emergency medicine, you guys are going to be collecting potentially some fluid samples like ascites, possibly, or pleural effusions if an animal comes in that dyspneic. I don't know if you do tracheal washes and stuff, but you might do those. But certainly if you're collecting a body cavity fluid, you should collect into EDTA because that preserves cell morphology better. If it's a pretty bloody fluid, I recommend collecting into red top, because if it clots, immediately you know that it's acute, either blood contamination or acute hemorrhage, or for an abdominal tap you may have hit the spleen. If it doesn't clot, you know that bleeding is pre-existing, because blood clots and defibrinates pretty quickly in the abdominal cavity. If you anticipate any for culture, we can do it off a non-anticoagulant tube, but it's better to put it in culture transport media. And always make fresh smears and submit with the tube, because we're trying to avoid some of these artifacts, which I'm going to go through, that occur with sample storage. And just like we do with hematology, refrigerate the tubes and not the slides to prevent or delay these artifactual changes. So really for body cavity fluids, that's where we have the most choices. And for us, it really depends on the cell count, unless we get a fluid from a cystic lesion on the skin where cell counts aren't required, then we're pretty much using these same principles that I'm telling you. So if we get the fluid and it kind of looks like this, you make a direct smear, you're going to see nothing. That's a pretty poorly cellular cell count. Essentially, we go by the turbidity of the sample to see, is it a highly cellular sample or not, understanding that milky fluids could be actually of low cellularity, but you're not going to be able to tell because it's going to look like milk. If you've got fibrin flecks or tags of mucus, such as a trach wash, we actually want that mucus because that's where the cells are. So we actually pick up bits of mucus. If there's a clot in the fluid, we will pick up the clot, and we'll look at the clot as well as the other smears that we make from the fluid. So if it's clear, we actually spin a portion of the fluid down and decant it and leave as little liquid as you can in the bottom, resuspend it and make a smear, and we call those sediment or concentrated smears. If it's really poorly cellular in our lab, we actually do a cytospin smear, and that's a specific centrifuge that none of you are really going to have, and that concentrates it. And with urine, we do a technique called the line smear, and you can also do this with poorly cellular fluids that look like this, because it concentrates the cells on a line, but it's a line smear of the sediment. So you first do a sediment, and then you make a specific smear type, which I'm going to show you. Now, I've added add protein to CSF. I don't know if any of you guys to collect CSF. I actually encourage people not to add protein, but you're going to read the literature. You're going to find that everyone says add protein. The reason we don't do it is that we're concerned that people will add the wrong volume of protein. The protein's going to dilute the counts. It's going to affect the accuracy of the counts. Yes, it will help the cells be preserved better, but it's also going to affect everything. And if you throw a protein in everything, guess what? Your protein concentration measured off the fluid is inaccurate. So keeping two separate portions, one with and without protein, is just too complicated. So just say, send in the CSF, we'll do what we can. And usually, if you've got inflammation in the CSF, we're going to pick it up. Those borderline ones we may miss because of deterioration, because CSF's a very low protein fluid, which is why the cells die there so quickly. So these are the hair dryers we have in the lab, and seriously, I go, sorry, I'm moving around, but I go there and I do this with the back of the slide, and it's on high, and I burn my fingers, but I dry the fluids really quickly. Why is that important? Because the cells spread, you can see what they are, and you can look inside them if they're neutrophils or macrophages for things like infectious agents. And I will show you the difference between slow drying and not drying. And this is really critical. Joint fluids, viscous fluids, trach washes, everything rapidly air dry. So every time I hear that hair dryer on in the lab, I know I'm getting more cytologies to read out, because that's how you tell. You will not hurt the cells, trust me. So the smears that we make from fluids in the lab are our classic blood smears, which are our wedge smears, because we like to have that feathered edge, because that's where big cells such as cancer cells go. So we really definitely need that. This is a line smear, which is actually a variant of the wedge smear. And instead of going all the way through the end of the slide and keeping going so you get that feathered edge, you actually stop 3/4 of the way and lift it up. And then what I do is I actually put my finger under the slide and tilt it up so that this line kind of goes back on itself a little bit, so it spreads it out a little bit so it's not too thick. And then I rapidly air dry that line first and then the rest of it. And what that does with the poorly cellular fluid is it concentrates that cell on the line, and that's where I go to. And we do that for urines all the time. We also do it with other poorly cellular fluids if we don't have enough to do a cytospin. And it's a really good technique. It's also more gentle on the slide than doing other smears, because the cells are just being drawn out gently. Often with the wedge smear, the regular blood smear type prep, the cells are ruptured out at the feathered edge. So this tends to preserve the cells a little bit better. But it can be thick, so you don't want to do it for a very highly cellular sample, excuse me. So I really hate the term squash smear, because people think you have to squash. So I want you guys to think about it as a contact smear. All you want, just like I mentioned with the blood, making the blood smear, is you want contact. You don't want pressure, because pressure is your enemy. You're going to rupture all the cells with pressure, and particularly fragile cells to begin with, such as those pesky lymph node aspirates with lymphoma. So even though it's called a squash smear, think of it as a contact smear. And this is essentially how I do it. I use the spreader slide at a 90-degree angle. Other people do it parallel to each other. That's fine. There's multiple techniques. You put a drop, or you put an aspirate. This applies to aspirates as well. Close to the frosted edge, not right on the frosted edge. I put the contact slide on top so that it spreads between, and then I very gently move them apart, maintaining that contact. Now, I don't do this because in my mind, and I was bad at physics, so I could be wrong, but in my mind that creates double the pressure as just keeping this steady and moving that. But again, I'm not putting pressure, I'm just putting gentle contact. So the one exception to that where I do put pressure is when I take a scalpel blade scraping, which is when you actually have tissue. And that's because it's naturally going to be thicker. Now, even lymph node aspirates, the other thing is, don't put all your eggs in one basket. Give us 10 slides and not one slide, okay? Because we can do additional stains. We're now doing all these special diagnostic techniques to differentiate lymphomas, the type of lymphoma. We can do other immunohistochemical stains on cytology smears. So you give us more slides, we can do a lot more with them. So make more slides than fewer. There's one vet who's great. She sends us 20 slides. We kind of sigh every time we get them, but we know we've got plenty to work with if we need them, but 20 is a lot. So the solid tissue is where I make the exception. So if you're taking a biopsy and you want to get better at cytologies, the best way is to read your cytologies and see what the histopath comes back. That will make you a better cytologist almost immediately, other than the things they can't see on histopath. But what you want to do is take a fresh cut surface and avoid ulcerated areas where there's going to be a lot of artifacts, superficial infections, as well as dysplasia, because secondary to that superficial inflammation, which can mimic cancer. So take the deeper tissue. You make imprint smears and always blot it with a bit of Kim wipe or tissue paper or gauze, just to get most of the fluid off so that the cells exfoliate. And remember that mesenchymal tissue with a lot of fibrous connective tissue will not exfoliate well. And what I actually do is, instead of actually putting the imprints like this, I actually roll a slide over the imprint. So kind of roll it. And I do about 3 imprints per slide, 3 to 5. If you do 20 imprints per slide, you're going to kill us because we have to look at every little dot, and it's really, really tiring. So it's better to give us 5 slides with 5 imprints per slide than 1 slide with 20 little dots on them. If I get a big enough piece of tissue and it comes down as tissue to compath, what I usually do is take a scalpel blade, one of those, anyone, and I take a fresh cut surface, and then I put the scalpel blade just like that, and I scrape. And then I wipe the edge of the scalpel blade on the slide, and that's when I put a little bit more pressure. So I know that areas are going to be squished to glory, but other areas are going to be beautifully well preserved, and other areas are going to be too thick. And that's also what we have to do as a cytologist, is we have to find the right area to look at. And that's also quite key. And there's also an art to it which you learn. And I'm going to go through that. So these are the stains that we use for both hematology and cytology. Obviously, we use a beautiful automated stainer. You want to take proper care of them. You want to top them up. You don't want to let them dehydrate. You want to make sure that there's no floaties or disgusting fungi growing in there, which I've certainly seen. We have bacteria growing in the stain, and ideally you should put it back in the primary container, or if you want to keep that primary container for when you're replacing the stains, you can put another secondary sealed container that's not going to dehydrate in use, and then just take it out when you need it. And these are Copland jars, which we use, which are really easy to stain with, but they do dehydrate if they're left in there. And it gets pretty grungy after sometimes, so it's a good idea to change it frequently, particularly with fresh samples. And, you know, if you're doing a lot of cytology, you'll need to buy Diff-quik every 6 to 12 months at least. And I think at least 12 months should be fine. So common artifacts you see stain precipitate, particularly with the blue one, and bacterial overgrowth, which I showed you a picture of in the hematology section. And lymph nodes always need longer. So we actually put lymph nodes and bone marrows through our stainer twice to get them adequately stained. So the first 10x overview is your first, is the stain adequate? And if we oil it, we're done, because then it's going to take another at least 6 hours for us to get that oil off and restain it. So our residents aren't allowed to put any oil on it until they think it's adequately stained. And when in doubt, put it through the stainer twice. So with Diff-quik, it's a little different. So what I usually do is I usually do a little bit of a longer dunk for lymph nodes in the blue, because it's usually understained in the blue. So I usually double the staining time in the blue for lymph nodes. And double, you don't want to live by any rules. You want to kind of get a feel for what works. But I usually do the blue a bit longer than the red for lymph nodes or thicker tissues like that. And you don't want to do that for thin samples like fluids, because it's going to be overstained, and that's not good either. And that's just a picture of stain precipitate again, which mimics coccyde just beautifully. One trick is you can gram stain that, because that will be red on a gram stain, whereas coccyde just jump out at you. Well, they should jump out at you with a gram stain. So again, know your stain, and I guess this is a Diff-quik stain, and this is our right stain. This is a round cell tumor, because they're discrete individualized cells. They've got nice round nuclei, and they look like fried eggs. And when we put our stain on it, the mast cell granules lit up. And those lymphoma of granular lymphocytes, those granules really stain up very poorly with Diff-quik, which I discovered to my horror once. And so now, which is why whenever I get an intestinal aspirate from a cat, I'm like, you've got to give me unstained slides, because I could miss this diagnosis, even if I'm looking for it. So that kind of freaks me out, not having my own stain to double check. So what we always do is we look at your slides first, and then we stain up ours if we need it. And it's kind of just a good security check for us, because we definitely like our own stain. So with cytology, again, like hematology, you want to be consistent, you want to be thorough. And you also want to remember here, blood sampling is great. You get the blood, you've got a snapshot of the blood. But cytology, you could be anywhere. So you may not even be in the lesion that you think you're trying to sample. And this is a lymph node, for instance, and you go straight into that germinal follicle, you're going to get more than 50% blasts. And don't make a mistake I made calling that lymphoma. And I've certainly done that, and I won't do that again because now I know better, but the first time you did, luckily the clinician was good enough not to believe me. So he called and said, this doesn't fit. And I'm like, oh, damn it, okay. So we don't like to make mistakes, but we do know our limitations, and this is one of them. I've certainly seen an aspirate of a lymph node going straight into the medullary sinus, plasma cells and histiocytes, that's all you're going to see, and erythrophagocytic macrophages, and you're like, oh my God, and then you get the cortex and you get lymphoid tissue, and then you go straight into a hyperplastic germinal follicle and it looks like lymphoma. So you've got to kind of know what the tissue is and what the architecture of the tissue is that you're aspirating in order to recognize what's normal and what's not. Again, consistency. So I tell our residents 10x is the most crucial view. That's where I'm already starting to work through what I think it is. And the 10x view is what I want them to give me a description, and in that first sentence, I should be able to tell what they're looking at. So this is really important, and what we're looking for at the 10x view is, again, it's all pattern recognition, but we're also looking for the good areas to look at. So this is an example of a tracheal wash stained with Diff-quik. So which of these is the best area? So I'm going to tell you right now, this is the best area because here I can actually see that the cells are well spread, and that's a neutrophil because I can tell it by its segment. Here's mucus. This is really thick. I'm not going to see diddly in there, right? I will look in there, but I'm not going to spend a lot of time looking for bacteria in there because I don't even know what the cells are, let alone looking inside of them. And right there is understained. Okay, so I'm not even going to bother looking there because that's wasting my time. So that's good stain, and that's the perfect area because I can see that these are neutrophils and they spread well enough that I can look inside their cytoplasm for something. If I come in here, those are also neutrophils, but I can't look at them because they're scrunched up, and I can't look for bugs in them. And this is suppurative inflammation, and I'm going to be looking for bugs. And at 10x, I'm like, okay, what am I seeing? And then suddenly I come across this, and I'm like, okay, that's a little funky. I want to look at that a little closer at 10x. So I'm going to go and look at this, and this is one of the cases I'm going to show you on the digital slide. So we've got all the stuff in the background, which I'm going to ask you what it is in a sec, but that is something that will clue me in that I need to pay attention to that. Oops. So then again, you can either use 40x, and I use 50x all immersion, and I go to 100x to look for bugs, but 50 is what I live by, and I love that lens. It's just great. It's $1,000, but it's awesome. And what are we looking for? We're looking for blood, and then is the blood contamination, or is the blood part of the lesion? So is there hemorrhage, or in the case of a body cavity fluid, diapedesis? So what we look for is erythrophagia, and this is a macrophage phagocytizing erythrocytes. And that tells us that there's either been prior hemorrhage or diapedesis if it's a body cavity fluid. Now that's if it's a fresh sample. If it's a stored sample, macrophages in a tube can start to phagocytize the erythrocytes within 2 hours of collection. And in fact, bacteria can be phagocytized by neutrophils and macrophages within 30 minutes of collection. So the sooner you make your slides, the better. Then I look for inflammation in the type and the cause. So this is the lymph node aspirate from a dog. Actually, it's cat because there's cat eosinophils. And there's a ton of eosinophils here. There's a mast cell here with the purple granules. And eosinophilic inflammation, I'm going in one direction. Now, I know some cancers in cats and dogs can cause eosinophilia, but generally I'm steering towards allergic or hypersensitivity diseases. And this was a cat with an allergic dermatitis. Then you're going to see tissue cells. So if you see blood, then is there inflammation? If there's inflammation, what type of inflammation? Neutrophilic, lymphocytic. And again, I've got guidelines in the notes as to the kind of inflammation that we look for and we categorize. And then I'm going to say, is there something else other than inflammatory cells? Are there tissue cells? And the first question is, are there tissue cells that should be there? So if you aspirate a lymph node and you see epithelial cells, clearly they should not be there, right? So either it's a metastatic tumor or you have an aspirated lymph node. And so we get that a lot with mandibular lymph nodes that people think are enlarged. They often will aspirate the salivary gland instead. And there won't be lymphoid cells, but there'll be lots of beautiful salivary gland cells. So should it be there? And if it should be there, is it normal? Or is it hyperplastic or dysplastic because of inflammation? And if it's not normal, is it neoplastic? And then what kind of neoplasm is it? And generally we break it into 4 categories. And I put the 4th under other because it's much less common. But there's round discrete cell neoplasms, epithelial, mesenchymal, and other, which are the endocrine, neuroendocrine, primitive neuroectodermal tumors, and all these new things that we're discovering. So that's a mast cell tumor, which is categorized under the round or discrete cell tumor. Beautiful purple granules. This is a right stain, so that's why they're so beautiful and purple. And they're individual discrete round cells. Other ones are histiocytoma, plasmacytoma, lymphoma, of course, and transmissible venereal tumors. And there are carcinomas that mimic these, so you gotta love the ones that mess with your head. Then this is a beautiful cluster of cells. They are roundish and quite large, but they want to stick together. They want to be together. If they want to be together and they're not being held together by matrix, that means that they're epithelial in origin. And again, is that normal for the site or is this abnormal? And this is obviously a fluid, and we should not see carcinoma cells in a fluid, but the first question is, are they mesothelial cells or carcinoma cells? And in this case, this was cancer because it had cytologic criteria of malignancy. And then we have the mesenchymal tumors, and this is a sarcoma. How do I tell this? Because there are red cells all between these cells, so even though they look like they're hanging together, they're not. And if you look at their individual shapes, they're more spindled than they are anything else. And this was a hemangiosarcoma, and it's showing gorgeous cytologic criteria of malignancy, huge nucleus here compared to this, and there was lots of other cytologic criteria of malignancy that I can't show in the slide. So facts from fiction. So as I mentioned, an erythrophage, and this is in a body cavity fluid, could be storage in samples. So if we see erythrophagia in a mailed-in sample and they haven't made smears for us, or if they, if we see them, then we're going to be fence setting. We're going to be saying the erythrophagia could have occurred in vitro, or there is truly hemorrhage or diapedesis into this cavity. So we fence it. You give us slides and they're good quality and we can examine them and we got enough cells to look at, and we don't see erythrophagia, we're going to default to it being an in vitro artifact. So that's where your slides help us. Again, you'll see phagocytosis of bacteria, which could be sepsis or contamination. And here you have these neutrophils, which aren't looking that degenerate. They're looking okay. There's tons of bugs in the background, and there's phagocytosis of these bugs in here. And this was actually a mailed-in sample where the bacteria contaminated the sample, they overgrew in transit, and were phagocytized. And as I said, within 30 minutes, this can occur. And so we look for intracellular bacteria to confirm sepsis. And in this case, we're going to fence it unless we have your smear to look at and see them in there. You also get cell lysis, as I showed you with the hematology. And samples collected post-mortem are invariably frustrating and often not helpful unless you're actually imprinting masses, because particularly body cavity fluids, you get clostridial overgrowth and you get exfoliation of mesothelial cells and pretty much cell death, so you don't even know what you're looking at. So other things that make our lives more difficult is understaining, and this is a Diff-quik slide, and this is clearly understained, so this needed longer in the blue. When we put this longer in the blue, I actually put it in our stainer after it had been Diff-quicked, it popped up, and this is lymphoma. So I couldn't make a diagnosis of that, but could of that. And this occurs if there's insufficient time in the stain or the smear's too thick and just needs double staining. This is a trach wash that was poorly dried. I have no idea what these cells are. They could be macrophages, they could be neutrophils. I assume these are macrophages because they're bigger. That one and that one, who the hell knows? I have no idea. So this is an area that I would have to look very closely in the slide to find a thin area that quickly dried. Otherwise, you know, we're just going to say this is not diagnostic. This is mucus and ruptured cells. And that's a slowly dried slide that was viscous to begin with. And these are cell ruptures. So this is a lymph node, and yeah, I'm suspicious of lymphoma, but I can't give you that diagnosis. And that's really frustrating when I've stained up every five of these slides and they're all the same. And that happens with squash smears when you truly squash it, and also some lymphoid cells are really fragile and they're going to break even with a little bit of pressure. So what I usually recommend for people to do there, if you get a good aspirate, make one a squash and then do a wedge smear for one, because the wedge smear is going to be much more gentle blood smear technique on a lymph node aspirate. And cell rupture, again, these are often what we see in lymph node aspirates. They just rupture. These is nuclear streaming, and these can start mimicking fungal organisms and strands of bacteria, so that adds an additional complication. And this is stained precipitate, huge chunks of it, and this is beautiful ultrasound gel. So when you guys are ultrasounding, make sure you wipe it off, because you stain and stain, put that through the stainer 10 times and the stuff just soaks up that stain and all your cells are understained around it. So make sure that you wipe off the ultrasound gel, and we know when we get new radiology resonance, because they always have that to start off with, and then we start writing comments and then it disappears. So those are some things that we have to live with, and again, these are the useful resources that we hope are just going to get better over time. This is a really highly cellular sample. So this is a pleural fluid from a cat that was severely dyspneic and febrile, had a beautiful inflammatory leukogram. And again, we've only taken a snapshot of the slide. But what I do when I scan at 10x, I scan the entire slide from start to finish. And basically what I'm looking for is the right area to go down on. Where is it stained? First of all, does it need restaining? But then if it doesn't, what am I seeing? And from 10x, I'm already going inflammation, I'm suspicious of cancer, I'm suspicious of this type of cancer. And then you go down and you confirm your suspicions from 10x. But the 10x view is where we start recognizing the patterns. If I'm seeing a lot of blood, my next thought is there inflammation along with the blood, or are all these leukocytes blood associated? And yes, I need to look for platelets and I need to look for erythrophages. So and there's a lot of inflammation. I'm looking at the types of inflammatory cells, and I'm looking for a cause. Sometimes you can see that at 10x. And of course, we always look for cancer, and then we always go down higher. So 10x overview, this is what I'm thinking. I have no idea what they are at this view because it's a little too high. And here I still don't know what they are. Here's something I'm going to come down and look a little closer at. But this is a highly cellular sample, and any area of the smear is good enough, but usually I go to edges like this because this is where the cells spread well. So let's go down and look at that area a little closer. So do you guys know what these are? So I don't know what they are. Well, I do, but that's because I've seen these a lot. So these are actually, looking at them, you don't know what they are because they're blobs of purple, right? They're purple blobs, that's what they are. But actually, if you look really closely, and can you like imagine a neutrophil nucleus there in there? Kind of imagine a scope. You've got to use your imagination a lot when you're doing cytology. So these are ruptured, lysed neutrophils. These are dying, dead neutrophils. And this cat had like a 400,000 nucleated cell count in its pleural fluid, which is never a good thing. It looked like pus, and that's exactly what it is. So you're looking at this, you're going to go, I have no idea what these cells are, and neither do I. And I have two choices. This is all necrotic cells, so this is a necrotic dead tumor, or these are dying neutrophils as part of an abscess. And in this case, I was pretty confident that they were neutrophils for the reasons that I'm pretty sure that's a dying neutrophil. You can kind of see its indented cytoplasm. So then I'm going to look for a cause. Now, these are not happy intact neutrophils that you can look inside them for phagocytized bacteria. But, you know, suppurative pleuritis in a cat, there's not that many things. So let's go back to that structure and see if we can find it again. And I need to zoom out. And there. And this is one there and there's one there. So let's go in here and zoom in. Okay, so this just looks like a gamush to you, right? But if you look really closely, can you see me tracing that filamentous thing coming off here? I'm going to prove to you that this is a sulfur granule, and this is either actinomyces or nocardia infection. Now, do you always see the neutrophils are sliced? No, we don't. But whenever I see the neutrophils and macrophages in a mixture of neutrophils and macrophages, like a foreign body type response, I look for these bugs. And cat pleural effusions, I'm always looking for these bugs. So this is just like pus and dead dying neutrophils, and here is our cause. And these are filamentous bacteria, and it's now no longer responding, so I'll have to shut it down and start. Oh, don't do that. I'll just end task and open the other one. And show you the gram stain, which will convince you, I hope. So immediately you can see that these are, here's the red, so the neutrophils are red, which they should be because, or the dead neutrophils are red, because that's when you do a gram stain to properly decolorize, if it's properly decolorized, cell nuclei should be red, so that's a good internal control. And if we go down on here, see the nice filamentous gram-positive bacteria. And let me go on. And see there was even more that I wasn't picking up. And see how they're forming these beaded filaments. It's really hard to get this in focus on oil, so it's never as good as a microscope, believe it or not, but it's pretty good. So this is a cluster of these organisms, and these beaded filamentous gram-positive rods mean it's nocardia or actinomyces. And these are really difficult organisms to culture, so you often have to put a special request to the laboratory to culture them, and they can take about 10 to 14 days to culture. Now, this is another thing about a gram stain that we don't like, is that in the background there are probably some gram-negative rods. I actually don't believe I'm seeing any in here. And it's really hard to see it. Now here's a beautiful beaded. You can see the beading in that there's dark and light stained areas on this filamentous bacteria. How much time do I have? 10. Okay, great. Then I can go through a couple more cases. And that's pretty typical morphologic features for nocardia and actinomyces. And here's another. So here you can see the bacteria coming off. They're often accompanied by gram-negative anaerobes, such as Fusarium and other species, and those often overgrow these organisms, and I know they're treated differently, so it's really important to look for them. And my policy on any suppurative inflammatory reaction is to gram stain everything in case you miss something, because cocci can mimic ruptured cells, and ruptured nucleus streaming can mimic bacteria, and it's always good to gram stain things. And gram staining for me is really more of a hunt for gram positives, because they're going to pop out like these, and less for gram negatives, because you can imagine gram negatives in any gram stain. You really can. So I use the regular stain, the Diff-quik or the right stain, to pick up gram negative bacteria. So that was that pleural fluid in the cat. And the cat actually did okay, believe it or not. So which one do I want to do next? Case 1. So this is a pleural fluid from a cat. That was a barn cat on a horse farm. And so I can't remember if these were direct or sediment smears. This is actually a mystery slide case. In our annual meeting, we have this really cool session where we get slides that we don't know what it is, and it's a great teaching case for residents. We see some cool stuff in these cases. And we'd actually not seen this before in this particular species, and it's been published since in JAVMA, which is in the notes that I just sent to Erin to give to you. So if we just assume this is a direct smear, for a fluid, normal fluid count on a pleural fluid should be less than 5,000 cells. So this is a really cellular smear. So this would be like 80 or 90,000 cells in there. So now let's go a little closer and see. I don't see big clusters of carcinoma cells, but what I am seeing are small little cells in the background, red cells, and these kind of big vacuolated voluminous cells, which I know are macrophages. So let's go down a little closer and see what these cells really are. And here, yes, that's a macrophage with something in the cytoplasm. Here's a neutrophil next to a macrophage. We also have quite a few lymphocytes. So lymphocytes, and they're small lymphocytes because they're about the same size as these neutrophils over here, and there's another neutrophil. So if we see lymphocytes that are small in a pleural effusion, we're going to think there may be a chylous component to the effusion, i.e. there's some lymphatic or venous hypertension. So here we have more very vacuolated cells, which are macrophages, and there's another cell type that I moved off, and here's binucleated macrophages. They're allowed to do that. They can mimic carcinoma, these macrophages. They can have mitotic figures, and they can be in big aggregates. And here's some neutrophils that aren't looking very healthy. They look somewhat degenerate. And this is the kind of stuff that we say this is fiction, so we would ignore this stuff. But let's go and look inside these. And I couldn't find that other cell that I was looking for. And again, this is fiction. This is a ruptured cell. So you want to find a well-spread area and something that's well-spread. So I kind of like that macrophage, and that's the cell I was looking for, and that's the plasma cell. Centric nucleus, deep blue cytoplasm. So let's zoom in on that. Okay, actually there's even better. So you've got something in there. So this is not stain precipitate. On our stain, bacteria are blue, and stain precipitate's purple. So there's a definite color differential. The other thing I look for with stain precipitate, it's often out of the plane of focus of the smear. And if it's in focus and it's in the same plane as like everything else is in focus for the cell, then I'm more concerned that it's truly not stain precipitate. The other thing I look for is uniformity. If it's very uniform and equal size, it's more likely to be an infectious agent or something real than if it's very variable chunks like you've seen all the stain precipitate there. So these look like coccoid bacteria, right? But they're in a macrophage. If you look around, there are actually some within a neutrophil, so this is an unhappy neutrophil next to lymphocyte, but there are a couple in a neutrophil that you really have to hunt for. There's a neutrophil jam-packed with them, and and there's another neutrophil right next to it with the bacteria right in there. You can kind of see it just over there. And the presence of coccoid bacteria in a macrophage is very abnormal. And when we see that, we think of one particular bacteria, and it's Rhodococcus equi. And we see that in horses, young foals, 3-month-old foals all the time. We see Rhodococcus equi in them, and that's what we expect. But this is pretty unusual in cats, but it has been reported. And so it's kind of a newly recognized disease syndrome in some cats, particularly when they're housed with horses, that they can get secondary Rhodococcus equi infections, because it's not something we typically expect to be a small animal pathogen. Are
they subclinical or?
No, they're clinical. They have a pleuritis for sure. And then the last one is going to be real quick because I don't want to hold up you too much for your next one because you don't have a lot of time between cases, and this was case 2, and this is something you may definitely see in the Sholter. This was actually a duodenal imprint, but you may see this in feces. And so these are imprint smears, and these are the little dit dots that I was telling you about that we hate because we have to look at every single little dit dot. But I'm just going to go down here. And again, we use first principles even when we're in an unusual site. So unfortunately, many of the cells are ruptured in the background, so I have no idea what that cell is, but you can kind of make out a neutrophil nucleus down there. So that's a neutrophil, and this is a slide from a friend of mine. There's lymphocytes here. That's a lymph. I can recognize that. I think these are macrophages. And so there's mixed inflammation. There's definitely a neutrophil here. And then there's this organism here in the background. And I don't think you're going to see it on here, which is such a pity because it's really pretty. But these, oh yeah, you can see it. Can you see the flagellae? So does anyone know what this is? Causes diarrhea, really putrid, foul smelling, disgusting, cow pie-like diarrhea. It's usually a problem in multi-cat households, so it could potentially get in a shelter. This is Trichomonas fetus. Very cool. It's the only one I've ever seen, and I was like, oh my God, this is so exciting. The cat ended up actually having lymphoma as well as inflammation. So it had intestinal lymphoma, probably small cell lymphoma, because that's the most common type of, we wouldn't have called lymphoma from the cytology in 10 million years, by the way, but we would have said protozoal infection, suspect trichomonas fetus, just knowing what it is at the site. But the 3 flagellae is pretty characteristic. And there are just a ton of organisms on it. He's a great source of slides. He just sent me a Clostridium piliforme in a dog liver, which is very unusual. That's also horse pathogens, all these horse pathogens coming into dogs. And I'm out of time, but I just want to share some of the fun stuff that we get to see as clinical pathologists. So you see, we get really excited. And some of us really love critters. I'm like a cancer junkie, but I do like critters. But we call them our little friends. And, we're always available for questions, and you can email us, and you can call us, and of course you can always send slides to us. We're more than happy to look at stuff. So enjoy the rest of your conference, and thank you for your time today.